Go ahead, Daraus. You can introduce yourself, and then we'll have David after you.
Thank you so much. My name's Daraus Vashchire, and from Uganda, and I head an organization called PVA Africa. It's a youth-focused organization. Yeah, basically that we do health promotion, education, and communication. I'll give details ahead. Thank you so much. I'm happy to see the faces I've been communicating with. Yeah, sure. Thank you.
So my name is David KAUC from Ghana. I'm the founder and the executive director of Youth Rise International, a youth-led organization that mobilizes young people and rural community to fight the intersection of extreme poverty, climate change, and health disparities. Thank you.
My name is George Jobe. I work for Malawi Equity Networks, an alliance of civil society organizations in the health sector in Malawi. I work there as the executive director. Thank you very much.
Thanks a lot, David. It was good to have your introduction, and George, it's good to see you once again, even if we're now in different locations. It's great to have you on the call. Yeah, we can move on to Kapil and Princess.
Hi, everyone, and great to be on this call. I'm Kapil Narain. I am South African and currently working with the Department of Health, doing my community service training in rural Free State, which is one of the provinces in South Africa. But I've been involved in various initiatives, and I enjoy writing pieces and calls to action in various global health initiatives. Yeah, happy to be here. Thanks.
Hi, Princess. We're just doing introductions, just talking about which organizations we represent, what our names are, and what our roles in the organization are as well, and which country you're joining from. She's responded in the chat. Okay, no problem, Princess. Thanks for joining us. For colleagues, as we continue with this session, yes, Princess is from Ghana. David, I see you have a comrade. Nice to meet you, Princess. Thanks everyone for joining on the call. Just the purpose of these calls is to just get a perspective of the important work that you do, to get to understand it more, as well as know the impact that you have, so that even in the event that there are ensuing opportunities, we'll know exactly who to point them towards. Another function of this call is just to get to understand the vaccine tests and treatments, pandemic preparedness activities in your countries and in your organizations as well. So for today, we'll be focusing on East Africa. We'll have presentations from Uganda and Kenya, just about the work that the CSOs in those countries are doing. And I'm glad that Daraus has already joined us, and Christine will join a bit later. So yes, Daraus is from Uganda, just the same way that he had said, from the Purpose Healthcare Africa in Uganda. He's going to be giving us his perspective on the work that he's been doing there in regards to COVID-19, as well as pandemic preparedness. And he also has an exciting new initiative that they're launching at PHC, which I think everyone would benefit from hearing from. But just before that, I'll give the floor to Taku just to give a short update. But you're all very welcome. We're happy to have you. Yes, go ahead, Taku.
Okay, sure. So I will just share my screen and give a short membership presentation. Okay, can you confirm if you can see my screen?
Yes, we can.
Yes, I can see you.
Okay,
Yes,
sure.
I can see.
Okay, sure. Thank you. Okay, so as you know, PVA Africa has a lot of members from different parts of Africa, from East Africa, from West Africa, Southern Africa, North Africa. So we normally work to ensure that the voices of Africans from different parts of the continent are meaningfully represented on global affairs. So this we only do it through collaboration with different CSOs that are working in different countries. So I'll be just giving you an overview of the CSOs that we are currently working in from the different regions of Africa, that is Southern Africa, East Africa, North Africa, Central Africa. So currently we have about 330 members from all 5 regions, with Southern Africa being the most represented region that has 37 validated members. So in Southern Africa, most of our members, they work in community mobilization, in HIV and in public health. In East Africa, which is the second most represented region in our membership, we have 22 validated members in East Africa, with most of our members based in Kenya or Tanzania. And we are also trying for this year, one part of our strategy, which we are actually in the middle of developing right now, is to increase membership in countries such as Somalia, South Sudan, where usually the health of many in those countries are denied because of political turmoil in those countries. We also have members in North Africa, which is actually the least represented region in our membership. Currently, we have 3 active partners from North Africa. So we are currently working with these partners to ensure that we increase our membership from this region. So we are trying to increase membership in regions such as Sudan, such as Libya. So if some of you here have CSOs that know that we collaborate with, that we can work with from these regions, would be happy if you could reach out to us, then we could reach to them to see if we can work together. In Central Africa, we have 70 validated members, with Cameroon being the most represented country in the region, followed by DRC. So part of our strategy this year is to try to increase our networks or our membership in Lusophone countries, that is countries that speak Portuguese, that is Equatorial Guinea and Cape Verde. We see that in our membership, these countries are not really represented. And when you say PVA Africa, it's an organization that is meant to represent the broad concerns of all Africans. It should have a footprint in all these countries. So we're trying to also increase our membership in these countries. Then lastly, but not least, we have also a footprint in West Africa, where I guess David and Princess are from. So David is from Ghana, Princess is also from Ghana. With 14 validated members in West Africa, with most of these members focusing on public health, research, and sex workers. So you see that most of our members are based in Anglophone countries such as Nigeria. So one of our strategies this year in this region is to try to increase our footprint in Francophone countries such as Cote d'Ivoire. So basically those are the outlook of our members in different regions of Africa. Then these members also work in different sectors, such as community mobilization, public health, as you have seen. So among our members, the most represented sector is community mobilization, which I believe Jaras is from. And the least represented sector is sex workers, which accounts only for 3% of the members. So our strategy also is to ensure that we increase our membership of people that represent sex workers, so that their rights are not violated in different regions of Africa. So this is basically the outlook of our membership in different parts of Africa. So I'll also give you an intelligence report that we normally gather from Gavi that shows the vaccination landscape on the African continent. So I'll be very brief here. So as of 22 June 2023, globally there have been 13.4 billion doses of COVID-19 vaccine that have been administered. That is globally. And around 68% of women members have had their population, 70%, at least 70% of their population vaccinated. And of those that have been fully vaccinated, 89% have been health workers, 82% have been older adults, and 66% globally have been the general population. Now, that's where the critical point comes. Only 27% of those that are fully vaccinated are in low-income countries. So basically, that's the global south, countries like Africa. So most of them are actually in Africa that have not reached the 78%. So I'll give you a snapshot of countries in Africa. So what you see that whilst vaccination started in around early 2021 in Africa, because of barriers such as inadequate infrastructure, inadequate training of health workers, supply chain issues, most countries have been able to attain the target that has been set at 70%. So you see all these countries that are shown here, and that is Nigeria, Senegal, South Sudan, have not been able to meet the targets that they have set. In countries such as Gambia, such as Central African Republic, they've been completely off track of targets that they have met. And only a few countries have been able to meet the goals that they have set from the start of the pandemic. And it's countries such as Sierra Leone and Zambia. So you see that of those countries that have that were not able to set to meet the targets that they have met, none of the countries have been able to achieve 50% vaccination rate. So that is Guinea-Bissau, Madagascar, Malawi. None of them have had their 50%, at least 50% of their population vaccinated, of which the target that has been set by WHO was 70%. And you see that of those countries, that the general trend that was seen is that of those countries that have been unable to meet the targets that they have set, generally the most vaccinated groups have been the elderly and health workers. Other sectors have been completely neglected or they've seen minimal vaccination. For example, people like drivers, people that are not frontline workers, have seen minimal vaccination in these countries. So the trend is also similar even in countries that have completely gone off track. For example, countries that have gone off track, only Tanzania has at least 50% vaccination rate. And in countries such as Burundi, there's actually close to zero vaccination rate in these countries. So this is generally the outlook of the vaccination landscape in Africa. So I think that's completely the presentation. If there are any questions, I'll be happy to take them. Otherwise, I'll be giving it back to Martie. Thank you.
Yeah, thanks a lot, Kuzwa, for sharing those insights. Actually, the insights were shared by the COVAX team. And I know sometimes a lot of data can get very confusing. So what we're doing as PVA Africa is we're organizing the data into a fact sheet that will make sense and provide some narrative into, what's actually going on. What does it mean when this percentage of healthcare workers have been immunized versus those who haven't? What does it mean? For example, we noticed that there's a lot of funding opportunities for data on older people in relation to COVID-19 vaccinations. So that's something that I think most of our members can also benefit from, when you're writing a proposal for funding as well, just including older people as well. In as much as I know David, Daraus, and everyone else focuses on the youth, there's also a big kind of gap when it comes to data and older people in relation to vaccines, tests, and treatments. So we'll be organizing all this information into a fact sheet, and which we'll be sending out at the end of the month. So it's going to be our first one, just another way of saying thank you and adding value to our membership. David already contributed to the first one through his statement on how Ghana was one of the countries that has a very high vaccination rate, but specifically focused on the urban areas. So what happens when it comes to rural areas. And we were gracious enough to receive a statement from Ghana on that. So we'll be releasing all those and involving the rest of our membership. At this moment, I'd like to welcome Daraus to present on his CSO work in Uganda and the work that PHC does and how they engage communities, because our theme for this meeting is community engagement. and empowerment, and finding out strategies on how better to engage our communities, because our communities are they're the ones who suffer the most when these pandemics hit, but they're also the ones who need to benefit the most from any interventions that come out from the responses. So I invite Daraus to take the floor. Welcome, and thank you for participating. Go ahead, Daraus.
Thank you. Maybe allow me to first get my screen ready.
Okay.
Screen sharing, then we can really proceed. So
no problem.
Can everyone see my screen?
Yes, we can.
Thank you so much. Once again, my name's Daraus Bashire, and I happen to found and also head Purpose Healthcare Africa, which is a youth-led organization, and in Uganda, actually in Uganda, operating across the country. Purpose Healthcare Africa is hinged on a slogan of promoting health for generations, sustainable health promotion interventions. And I'm happy to be part of the PVA, trying to advance the agenda of community empowerment and vaccine justice. So allow me, but maybe before that, I will happen to also support an initiative under the African Union. It's called African Union COVID Bingwa Initiative. It's under the Saving Lives and Livelihood Program. I happen to be supporting that initiative. So understanding community engagement and empowerment for COVID-19 response, preparedness and response. Let me put in this kind of format. Okay. So maybe about Purpose Healthcare Africa. As I said, it's youth-led and founded non-government entity that was established in 2018. And it addresses health issues and social determinants. And yes, we currently operate in the entire country, Uganda. We envision to achieve an empowered population and that is resilient to contribute to sustainable health and development. And our mission is provide sustainable, equitable, like we are talking about vaccine justice and innovative solutions to contemporary and emerging public health challenges in Africa. Of course, mainly through health promotion. So area of focus, generally we do health promotion, education, and communication. But in specific terms, we do social behavior change communication, we do risk communication and community engagement, like we are going to elaborate more. We do research that feeds well, that aligns well with health promotion, and mainly that is knowledge, CAP studies, like everyone can understand, knowledge, attitudes, and perceptions, such kind of surveys. Community dialogues, of course, community, that's an element, that's a key aspect of community engagement. And, can't do health promotion when you don't have IEC, information, education, and communication materials. So when we have resources, we do development, and if there are those that are existing, we do review to suit the situations and the times. Of course, we do advocacy for health, we do demand creation, generation for health services. We do capacity building. Like recently, we had some capacity building in one of the districts where we oriented and trained community health workers. For us here, we call them village health teams. We train them on health communication for HIV among the young people. We do a lot of media activities in print, broadcast, social media. For those of you who will be able to follow us, we do a lot of social media work. Now, in the COVID-19 response, preparedness and response, under risk communication and community engagement, we did a lot of work in the communities. We talk about what COVID is, how is it transmitted, how prevention, and also emphasizing the issue of risk perception, because you know, you remember that in the country context, Uganda, people thought that actually COVID-19 was a biological weapon for government of Uganda to get money from donors, and also the government officials from the ministry to get some money from the different donors. Now, under community engagement, we also had a number of engagements with religious leaders. Of course, all these efforts supporting Ministry of Health. So on this, on your, is it on your right or on your left? But it's clearly indicated religious leaders there. Yeah. So media activities, that is the Rouse, me myself, where we did and continue to do a lot of media engagements where we communicate about the of course, as of now, I can assertively state that the risk perception has gone a little bit down, because the prevalence, the incidence of the virus has really gone down. So, but we continue to talk about COVID-19 as a reality and the value of vaccination. So we also supported the ministry in our volunteerism with technical support supervision, where you see with the gentleman, the one in a blue shirt is a DHO of a certain district. And on the other hand, I was interacting with the vaccination teams in one of the districts in the country. So offering them technical support, what are challenges are they facing, how they would go about them. Health education, this is at a facility. So in our movements, we would reach out to the different health facilities, find people that have come for vaccination, and we do on-site health education, talk about the virus and what risk are they exposed to as a community, and how best can they prevent, of course, emphasizing vaccination as a key preventive measure. So social media, you see, we continue to talk about vaccination in our social media platforms, and that is our Twitter handle if you try to Google it out. So because the number of the young people are on social media, so we leverage on the power of social media and its reach, talk about vaccination and enhancing and trying to emphasize preventive and positive behavior. Of course, those are some of the VHTs during the COVID-19 pandemic, because our VHTs are the key contact person with the community, and they do a lot of mobilization, community mobilization. So, of course, we supported the ministry voluntarily to offer some of these services. Now, to talk about the significance of community engagement and empowerment, of course, it is always important to have a bottom-up kind of programming, engaging communities so that they view the intervention as ours, not for us. Ours is better than for us. It's like, you know, you send something for the people, but when it is generated by themselves, owned by themselves, it is theirs, ours, in the context of the population. Now, it's really important in building trust and credibility for compliance. You know, we had a number of standard operating procedures for COVID-19 prevention, but it takes time. It took time actually for people to believe that this is actually theirs. You know, credibility for all these, for example, SOPs. You know, it may be normal to wash hands to prevent the particular disease, but it takes time for people to actually trust what you're telling them, and also attaching credibility to what you're saying. What are you saying? What are you doing? Is it really of value? Is it helpful? Is the vaccine you're trying to emphasize really credible? Who is the manufacturer? All these issues trying to link around. So engaging communities builds that trust in what you're talking about, in the product you're trying to sell. So it took time for us in Uganda context to build after a lot of rumors. For example, it took time for people to believe that that Pfizer or any other brand apart from Johnson was a credible vaccine, until we had to engage a lot communities, engage the key influencers, religious leaders, engage the political leaders, so that the communities can themselves accept and believe that actually what you're telling them. Raising risk perception. I can tell you that some people would really wouldn't see a problem with COVID-19, and they wouldn't see any value in washing hands, because they believe that the risk of contraction was very low, and actual risk of death was low, until we really involve the communities actively to appreciate actually that the risk was there. Acceptance and ownership. You realize that, now let me talk about the private sector. You know, there are people, business persons, who themselves would later on appreciated the value and invested in mobilizing their clients for vaccination. We had the brewing companies, the Uganda breweries, the telecom companies. So the communities accepted and, you know, took it up and started, you know, seeing the interventions as themselves. Of course, facilitates effective communication. Now, it was easy. It is easy with community engagement to understand what is in the community and the different feedback mechanisms that are able to give. And this works well. This worked well in the early stages of the pandemic response, and still continues. Now, relationship with the community. Of course, when you interact with the community, you begin to create that bond, and actually getting that feedback and monitoring the rumors becomes easy, and, you know, demystifying the myths and misconceptions reduces anxiety. You know, everyone appreciates the fact that COVID brought a lot of anxiety. What is this disease? Is it really there? What is the effect? What is now? What is, you know, what as the community? What has befallen us? Are we safe? So engaging the community to appreciate that actually this is a disease. This is how we're going to prevent it. And this is the likely effect that if we don't obey the comply with the regulations and maybe get vaccinated, this is what we are heading for. Then tailored interventions. Of course, different communities, different regions, we have sociocultural differences across regions that are appreciated after engaging communities. I can tell you, in Karamoja, which is part of the northern Uganda, it is a pastoral community, and they are always moving in a groups called kraals. And if you don't engage community understanding, what times of the season are they going to be in this particular place? What time of the season are going to be moving? You may not be able to organize a clear intervention, even if it's a vaccination campaign. So for community engagement, it helped us, for example, understand some of these sociocultural differences, and that feels well. That augurs again. That explains the point of appreciating diversity. Religion, for example, Muslims will be at the mosque on Friday and organizing a vaccination campaign. Targeting them on Friday would be most appropriate, because most of them have gathered for prayers. So understanding, demystifying myths and misconception, I talked about it. Secures active participation of local communities. People own the intervention, and they actually, this was well with the COVID-19 response. Understanding specific interest groups. For example, the fishermen are always active. They are out there in the lakes during the night. During the time, they are sleeping. So engaging communities will help you appreciate all these kind of contexts, and also making sure and helps you reach out these communities or special interest groups better. Enhancing demand for vaccines. Of course, that is very clear. Understand what are their needs, how best to reach them, who are the key influencers, and what are the issues that the community has about the vaccines. Assessment of accessibility obstacles, like in Karamoja, they are what we call cattle rustlers. And if you just go there without appreciating the community specific issues, you may have to face a lot of challenges. Social listening avenues, there are rumors in the communities, there are myths and misconceptions. So, but when you engage the communities, you come to appreciate how best you can capture these rumors, these misconceptions, and ways to address them. Yeah, when you engage the communities, it's an expression of care and concern. Oh, the government is concerned. Okay, this is good. So we can, people appreciate your care, and this enhances the demand, rather the uptake of the vaccine. Leverages on community resources. I've talked about the private sector. We engage the communities, the different stakeholders, and people invested. Actually, some of these companies organized vaccination outreaches. They funded these outreaches themselves. They would come, they would reach out the ministry and request for themselves to organize these outreaches. Understanding health-seeking behaviors. By the way, in Uganda, we have what we call traditional birth attendants, rather traditional medicines, or we have witchcraft or witch doctors. Some people actually would prefer seeking, they would look at COVID as being able to be cured by the traditional herbalists or the witch doctors. So when you reach out to these communities, we have cults in the community, cults, those who believe that vaccination doesn't work. But when you engage these communities, you start to appreciate and really dig deep into the cause of these beliefs and design strategies and approaches to address them. Now, the best community inclusive and empowerment and involvement approaches: consultations, dialogues, town hall meetings. We've participated in this one. Understand what is in their mind. What are they thinking? How best can we redirect these minds? Target influencers. Now, in Uganda, for example, when you go to the Buganda, we are organized in 2 kingdoms. In Buganda, if a king stands up and says people get vaccinated, no one will say no, and you'll wonder, you'll be overwhelmed by the turn up. In Karamoja or in Teso, they have their chief, the paramount chief. When they make a statement, in the Catholics, you go to this, you go to the archbishop or whoever, depending on the religious organization. When they make a statement, they will all follow. Currently, in the ghettos, people believe in the current leader of a political party called NUP, National Unity Platform. He's called Bobby Wine. He's a musician also. When he makes a statement, all the ghetto youths will go and get vaccinated. So, of course, targeted capacity building. VHTs are very key in mobilization. So offering capacity building, some of these key, the key health personnel, the health workers. So looking at empowering them with the information and the skills to do kind of advocacy. For example, the VHTs, they always link up with the health facilities, and they ask for vaccines to carry out the different vaccination outreaches. Empower and train community health workers, the VHTs, appreciating diversities. Yeah, we talked about the fishermen, their lifestyles, the Karamoja communities who are always moving. They have different uniqueness, which has to be appreciated. Collaborations, fostering collaborations. We have civil society, we have private sector, we have CBOs, community-based organizations. I think trying to foster collaborations can leverage on the resources and the mobilization powers that facilitate some of these community empowerment initiatives. Feedback mechanisms. We are on radio, listen to what is happening, go to the community, provide them. If there is, for example, during vaccination, we would have a number of brands. We started with AstraZeneca, then Pfizer, then Johnson. So providing, keeping in constant communication with the communities serve to impact a lot in acceptance and in strengthening demand. Policy co-creation, of course, designing some of these regulations without community or some of the key players most likely brings a lot of rejections. But when the community or community leaders are involved, there's that kind of acceptance and welcome and hospitality to an intervention. Listening to the community, the ears keeping on the ground and giving them the ears. The communities appreciate an intervention when you keep in constant communication with them, so that they appreciate that you're with them and you give them attention. Now, I try to go through so that I'm in my given time, allocated time. Now, I want to, someone presented before, that Uganda is one of the countries that have not reached the 70% target set by the WHO. And I can assure you that, I can tell you that one of the key challenges is that some of these special groups have not been reached out to. The slum communities, the fishermen, fisher folks communities, there are some of the areas that have not been given special attention. Some of these campaigns have been general. There are no specific interventions, no specific campaign that have been given to some of these special communities. Especially, let me tell you this: the slum communities constitute about 4 million%, over 4 million of Kampala, of the city dwellers, which is 60% of the population. But there's no deliberate attention or campaign that has been given to this. And that explains why Uganda is still below. Now, what we think as Purpose Healthcare Africa is a focus, is a special attention to this. So we are thinking about, we are trying to see how we implement an activity in the slum communities, and which is aimed at enhancing awareness and vaccination in these slums. Now, Kawempe is just one of the divisions, or call it a district, but the whole Kampala has about over 20 slum communities. And I can really tell you that if you reach these communities, now Africa CDC under the Saving Lives and Livelihoods has been partnering with AMREF to create some outreaches, but this is not enough. It is really not enough, and I can tell you that the turn-up has been so huge, but the impact, it is there, but a number of areas and the slums have not been served to a great extent, and that's why we are thinking that we need number of players that in this area of vaccine uptake enhancement, vaccine justice. It is high time that we really give focus to these communities, and we are aiming at contributing to vaccine COVID-19 prevention in these slum communities through increased awareness and vaccination activities. And our objectives are to increase awareness among the residents in these slums and promote COVID-19 vaccination through outreach, vaccination outreaches, and also civil society players and other private sector influencers. We believe that if we do this, we shall do great. And we plan to identify, under this objective one and of enhancing stakeholders, we hope to identify and map out key stakeholders and influencers, political, religious, artists and musicians, and through an engagement with workshops, of course, where we reorient them. Because I want to tell you that the risk perception has gone so down that you tell someone to get vaccinated, they will tell you that no one can still die of COVID-19 because COVID-19 is not there. So again, revitalizing the risk perception about COVID-19 requires, a re-strategizing, a refocus, and that can be done by engaging these key influencers. Like I said, the king of Uganda, if they stood up and said, "You people, COVID, we need to eliminate COVID, and this can be done through vaccination," the next day you organize an outreach, you'll be overwhelmed. Awareness creation, we hope to really do a reorientation of VHT, because the VHTs need to have updated knowledge on COVID-19, better communicate, have a better way to communicate. The time during when the COVID-19 was at its peak, the communication language that was used cannot be used now, because someone will tell you COVID is not there, and yet it's still there and the risk is still there. So reorientation, it will be key. Community activations would need to have an event where we bring, maybe you can talk about, we can bring some influencers, and then we do an activation towards the outreaches that we shall be holding. VHTs are very key. They are key influencers. They are listened to in the community and can support the mobilization. Local media activities. I can tell you that we have what we call the community audio towers, which are doing great work. These are erected address systems that are stationed, but they project the voices to a bigger audience. So if we use these ones, because the slums are very, very densely populated with close proximity, with close range houses, not even close range, so compacted. So when you project the voice upwards using the community audio towers, you can reach greater population. Vaccination, promoting and facilitating vaccinations. Of course, we hope to orient vaccination teams on the current vaccination best practices. Yeah, they need to be reoriented. Of course, rotational vaccination outreaches. You have a vaccination outreach here, tomorrow you can organize it in another place so that there's equitable and all the areas are really covered. And we of course technical support from the PVA team and any other person. And of course, with a lot of funds to facilitate the operations and the coordination. And of course, our call to everyone here is support us actualize this intervention so that we make sure that we have we have 70% coverage or even more, especially when we have these special communities really covered. And for this matter, I would really thank you so much for your attention. And of course, sorry for going through very fast, but because I was given 15 minutes and I had to obey the guideline. I thank you so much for listening to me.
Thanks a lot, Daraus. It was very insightful to hear that perspective from Uganda, especially knowing that people may have moved on, but you know that people in urban areas, especially the slums, might still be suffering some of the effects of the pandemic. So it's good to hear you covering that point of view and to understand how you engage with the community for their benefit. I think we can note our questions down just in the interest of time. As I welcome Christine Yakama, our next speaker. So welcome, Christine. I'll share my screen to project your presentation.
Good afternoon, everyone. Thanks so much, organizers, for giving me an opportunity to present. I'll stop my video for now and I'll do the presentation. I'll begin by saying in Kenya, we have two levels of government. We have the national and the county government. I work at the county level, that is Kakamega County. And my main focus today will be on the health sector, whereby health in Kenya is fully devolved, but it's not fully devolved because if it was fully devolved, our counties should be receiving 80% of the national budget. But it's unfortunate that they are receiving 60%, which is just a drop in the ocean. So I'll begin by saying, as Good Health Community Programs, we are a women-led grassroots organization working in Shinyalu Sub-County, Kakamega County, Kenya. Next slide. We advocate for women's, children's, and adolescent health. And our main program is sexual, reproductive, maternal, newborn, child, adolescent health. Plus now we have immunization component in it. Next slide. With 3 years since the first COVID-19 case was reported in Wuhan, China, the disease still remains a mystery to people in Shinyalu. Infant mortality rates, immunization coverage, and increase in new HIV infections impacted our work. In Kakamega County, we pushed for a policy that is called Kakamega County Maternal and Family Planning Act, which was encouraging mothers to attend ANC clinics. And when they attend the ANC clinics, they're being given a stipend of 2,000. Initially, we were losing a lot of mothers because they never used to go to deliver in health facilities. They normally used to go to traditional birth attendants, which caused a havoc in our community. So one way we decided to motivate them is by giving them the county government to allocate money towards that program. And then on immunization coverage, we were doing well, but now the numbers reduced during COVID-19 with the messages of social distancing. And then there was that issue about people are not allowed to move around. It became another issue. And we were able to, what we managed to do during the COVID-19, we did mass education COVID-19, whereby we were making use of the market days. We go around and sensitizing women, the importance of taking their children to health facility for vaccination, and also ensuring that they wear masks. And then we also encourage them also to use sanitation practices, especially now on using water and soap to clean their hands. Next slide. And then there was the issue of vaccine hesitance. When the COVID-19 vaccine was introduced, people had the myths and misconceptions around the vaccine. especially others were saying it's causing infertility. And then 2, one cannot contract COVID-19 after vaccination, of which, although you are fully vaccinated, people will still get the coronavirus disease in what is called breakthrough infection or breakthrough case. And then others were thinking it causes blood clots. And then others were mistaking it to family planning method. And then the vaccine, others were saying it was unsafe for pregnant women, of which it wasn't the case. It was safe because we might end up losing women, especially mothers, giving birth to preterm babies. Next slide. So part of the work that we've been doing, we decided to carry out social audits, whereby we try to find out the vaccine rollout of COVID-19. And as at 31st of March 2022, this is what we did. We began a vaccination exercise between 1st of March 2021 to 31st of March 2022. The primary objective of the audit was to determine the efficiency and effectiveness of the COVID-19 vaccine rollout in Kakamega County. The audit involved a review of the budget, that is the county budget, sources of vaccine storage and distribution. Kakamega County received 870,019 doses of various vaccines during the period under review. 734,469 doses were still in stock at the time of the audit. By 31st of March 2022, the remaining 96,325 vaccine doses were comprised of expired, damaged, and unexplained diseased variants of 59 to 35 doses as at 31st of March 2022. A review of the Kakamega County Health Services budget for 2021-22, the county government did not budget for the COVID-19 vaccination activities, but instead used the budget for routine immunization to cater for the rollout of the exercise. On the sources and distribution of vaccines, the source of vaccines to the county was the national government through the Kakamega Regional Store. The distribution flow was from the regional store to the sub-county stores and to the facilities which administered the vaccines. On the storage of vaccines, the Kakamega regional and sub-county stores complied to some extent with the storage conditions set out by the Ministry of Health for COVID-19 vaccines. However, weaknesses were noted in the storage at the facilities, such as inadequate storage equipment and temperature monitoring tools. So what we've been able to do, after sharing the audit findings with county government, we were able to lobby through the county budget making process, whereby now the health budget should be getting an overall budget of 35% of the whole county budget. And we've been able now to emphasize immunization to get 90%. Why 90%? Because we've seen that Kenya, we were transiting to a low middle income country. So over reliance of donor funds, we are trying to cut it out. So the county government, in their budget, they need to allocate money towards immunization. And also the immunization coverage we've increased. Initially, we had 315 sites. At the moment, we've increased them to 375. And then what we are doing now, we are doing what we are calling, they've rolled out primary health care, whereby now we are having mobile clinics in households, whereby now we have the in charges of health facilities working up with, we are now not calling them community health volunteers, but community health promoters, whereby now they are doing the prevention and curative at the community level. And then what we are also doing, we are developing policies. And one of the policies that we've come up with is one for the vaccine that is there at the county level. We are waiting for the governor just to assent it. and then it becomes a policy. My message is that if there's no time for your health today, then no health for your time tomorrow. Thank you. How I wish, Martin, next time when you organize a meeting, you give me favorable time.
Yeah.
It was a rush, so I wasn't able even to share more about what we are doing and how we are engaging decision makers. Thank you.
Thanks a lot for your presentation, Christine. We'll definitely allocate more time next time for the presenters. But thank you for adhering to the time restraints. And we thank you everyone who was able to join. I don't know if anyone has any questions for either of our two presenters for the short time that is left. Yes, go ahead, David.
Okay, so sorry, we had some power cuts, so I was off for some time. So I missed the latter part of the first presentation and also the beginning of the second presentation. But I was curious to find out from the first presenter, after such a wonderful and very rich presentation, in terms of the social and behavior check communication, were there any diversity in terms of language? Did they use English as a language? Did they use local dialects? And if they did, what was the impact? Did it make any difference in terms of diversifying the different languages that they might have used? And then the second presenter, thank you so much for such a great presentation. I am interested to find out what impact is the research making with the department, and how are they, since you mentioned that your country is now in middle income, are they committed in terms of generating internal resources to allocate towards making sure there's vast equity, or are they still going back to the international community for aid, which usually come with all the constitutionalities and the restrictions? Thank you.
Thanks a lot for your questions, David. I hope Daraus and Christine, you've noted those questions, but before you respond, let's just take a final question that's from George, so that when you're responding, you just respond to everything. So go ahead, George.
Okay, thank you very much. I would want to appreciate the two presentations. My question is, with the examples given that you have done community mobilization, community awareness, social behavior change, communication, and have attended some positive change. At the moment, is there 100% acceptance of vaccines? I'm asking this question because, like in the case of Malawi, you will still have some pockets that have attributed their fears or have classified their fears from the COVID-19 vaccines to other vaccines. The polio vaccine comes, they will say this is the COVID vaccine. Polio vaccine, typhoid fever vaccine comes. So how is the situation at the moment? Has there been achieved a total acceptance of all the vaccines, or you still have some pockets of hesitancy? Thank you.
Thanks for your question, George. I think we'll take Daraus first, and then we'll have Christine respond to the questions as well. So Daraus, go ahead and respond.
Thank you, George and David, for first of all following up the presentation. It's really energizing and motivating. First of all, Uganda, for Uganda's context in terms of languages, Uganda has 6 main regions, and each of those regions has a dominant language. We may say dominant doesn't mean that there are no other languages, but they are there. But the dominant language, which is regionally, utilized or used, and at least generally interpreted and used as a general communication language in the region. So when we are designing, when we are doing these interventions, and of course supporting the different health players, These are the languages that we use to generate IEC materials, the information, education, and communication materials, be it audio, visual, audio or audio visual, even when we are doing interpersonal in the community. So we first of all is appreciating the language that is universally used in the region, and then, deploying it to do communication. Of course, English remains a constant. There are those that will be for English across the board. Then about fears for COVID-19, these ones remain, especially advanced AFIs. There are AFIs, people saying, I got this after the vaccine. So those ones remain. But of course, community engagement and constantly communicating, constantly talking about the goods about the vaccine will always bridge that kind of gap to address the misconceptions, the myths. But we are lucky in Uganda that these kinds of things have really gone so down. About COVID-19 vaccine hesitance has really gone down, and what I've realized is that the communities are still willing to get vaccinated. At least I've moved in these communities where the AMREF and Africa CDC is implementing some of these outreaches. The community is still willing, but I think the awareness is still lacking. So there are pockets of the hesitancy. There are those who will tell you that my colleague has told me that your manpower reduces when you get vaccinated. So those ones, of course, may not really go away, but generally the vaccination acceptance, the vaccine acceptance is really significantly appreciated and continues to do great. I thank you.
Thanks a lot.
Maybe to respond to George asked about vaccine hesitancy. It's still there. But what we are doing at the moment in my sub-county, we are doing a rapid response initiative, whereby now we are targeting churches and schools, whereby now we are trying to mobilize the community and they are able to access the vaccine. And then my sister Princess Akona has asked me how CSOs are working with the government. I'd like to let you know that in Kenya, our constitution, Article 1, sovereign power belongs to the people, and nothing can be done in the counties or approved without the citizens' voices. So how the CBOs and the community are engaging the government is through public participation. Two, we have the County Budget Economic Forum, whereby we have representation of people living with disabilities, civil societies. They also have a slot, and also members of the chambers. And also now in ministries, we have sector working groups where the CSOs can work in those groups, whereby they can influence the budget and also policies. And also we have the technical working groups in the ministries. So CSOs, that's how they work. They're being brought on board, and the community. They always say nothing for us without us. So it's you to fight for your space in the government, but you're ensuring that you're not being compromised. Over to you, Martie.
Thanks a lot, Christine, for your responses. I trust everyone got enough material when it comes to the responses from our speakers today. I'd just like to thank you for attending this session. It was really informative. Thanks a lot to Daraus and Christine for providing your perspectives from Uganda and Kenya respectively. It was really informative, and I hope we all had a fruitful session. I can see we had a near complete and 100% complete representation from Africa except North Africa. So it's good to see that even during the membership meetings, we have that kind of representation. It's very encouraging. So in respect of your time, I'd like to bring the session to a close and just wish you a great afternoon and a great week ahead. We'll send a reminder for the next meeting and reach out to some of you as well for presentation purposes as well as participation. Thanks a lot and have a good afternoon.
Thanks a lot.
Thank you, Martie. Bye, everyone.
Bye.
Bye.
Thanks so much, PVA Africa team. Nice to be here.
Okay, bye. Thanks, everyone.
Ah, angisathi bantu